Uh, Okay, hello, I'm Dr. Rani. I would like to make presentation related to neuromyelitis optica, or previously known as Devic disease, or neuromyelitis optica spectrum disorder. And today I will be more concentrated about make difference between NMO versus MS. So let's start my presentation. Okay, first of all, let's determine what is this neuromyelitis optica, and then I will try to explain what is the pathogenesis, what is the clinical characteristic feature, management and difference, and differential diagnosis. Okay, neuromyelitis optica, as you can see here, it is an inflammatory disease which causes demyelination of central nervous system, and the name directly tells us that in general in NMO we have problem in the like central nervous system, especially in the spinal cord, and also optic nerve. It looks like a little bit multiple sclerosis, but as I already mentioned, I will try to show you what is the difference between them, right? Okay, let's start first of all. What is the risk factor of NMO? As I already mentioned, it is one of the autoimmune conditions, so you won't be surprised if I tell you that it is more commonly seen in female sex rather than males. As you can see here, it is 9 times more prevalent in females compared to males. Also, we should more likely this neuromyelitis optica should be seen in Asian and African descent population. And what about median onset of neuromyelitis optica? It looks like MS, multiple sclerosis, because we know that also average onset of MS is also 40 years, but it is same also in NMO spectrum disorder, but it should be developed from 20 to 70 years old patients. Okay, now I would like to tell you more about pathophysiology of neuromyelitis optica. As you can see here, NMOSD is a primarily astrocytopathy. So what does it mean? It means that it primarily affects astrocytes, and after that it will cause secondary damage of oligodendroglyocytes and demyelination, right? In this condition, I found out very interesting approach. What is the explanation of development of this condition? And it is autoantibodies, IgG antibodies, which are against 2 aquaporin channels. As you can see here, I will use this illustration to make like more clear pathophysiology of neuromyelitis optica spectrum disorder. Here you can see these are the blood and these antibodies, autoantibodies against aquaporin channels will be produced peripherally, as you can see here, by plasma cells, and then it will cross to the BBB or blood-brain barrier, and it goes to the CNS, right? So here you can see this is the astrocyte, and these autoantibodies against aquaporin channels will bind to the astrocyte food processes, as you can see here, and it will cause activation of complement system. How? Here you can see this is our complement proteins, and especially it will activate late complement proteins from C5 to C9, which is very important to make production of membrane attack complex. So when we have production of membrane attack complex, or MAC, it will cause primary damage of astrocytes, and it will damage these water channels, aquaporins in the astrocyte. So it will cause secondary damage of oligodendroglyocytes. And how? Because this water imbalance, because of the main explanation of imbalance of the water, right? So water imbalance will cause oligodendroglyocytes damage and demyelination, which is one of the important characteristic for neuromyelitis optica. And rather than this, in case of NMOSD, we have granulocyte accumulation and inflammation development, right? So in the second part of my illustration, it is more about association and a correlation with the treatment related to humanized antibodies, but I will tell you more about this in the little bit later, right? But it is mainly about markers which present into the B cells to finally avoid production of antibodies against aquaporin channels, which are AQP4. Okay, and now what I want to tell you before I go to another slide, it is that these aquaporin channels, which present, which will be damaged by autoantibodies, are mostly prominent in the central neural system, especially in the area postrema, also spinal cord, and also optic nerve. This is the reason why mainly in neuromyelitis optica we have damage of these three main parts. And I will step by step explain what should be the characteristic features of one of each following, right? Okay. Now let's start from clinical features. First of all, I want to tell you that previously this neuromyelitis optica was known as one of the variant of MS, but nowadays they find out that it has a fully different pathophysiology. Also, it has a fully different management, prognosis, and so on, and characteristic features also. Here you can see 50% of cases with neuromyelitis optica involves transverse myelitis, and I will show you some kind of characteristic and features of transverse myelitis. For example, a lymphocyte, one of them should be, but it is not enough only to make diagnosis neuromyelitis optica or maybe, for example, MS, right? But in 50% of cases, as we can see here, it involves transverse myelitis. Also, 35% of cases it involves optic neuritis, which is mainly characterized by ocular pain. And rather than this, we know that it is characterized by visual loss. It should be bilateral or unilateral, but what is the difference between MS and neuromyelitis optica in case of to make differential diagnosis? In case of neuromyelitis optica, this like a visual loss should be bilateral and it should be permanent. So it is more like this optic neuritis is more severe compared to MS. Okay, and another one, in 10% of cases, it should involve transverse myelitis and optic neuritis together. And the last one, in 4% of patients, it should be characterized also area postrema syndrome. I hope you remember that area postrema is located into the medulla. So this area postrema is very important. And in patient with neuromyelitis optica, if we have involvement of area postrema, patients will develop nausea, vomiting, for example, and hiccups. So this is very important characteristic feature for neuromyelitis optica. And I would like to mention that previously and sometimes 4 out of 10 patients with neuromyelitis optica is misdiagnosed with MS at first. Okay, now let me show you some ocular signs and symptoms for neuromyelitis optica. In the first, initially it should be present with acute flu-like illness, like it is, for example, fever, myalgia, headache. But after that, we have another symptoms, like it is, for example, optic neuritis or myelitis. I would like to show you this picture, which represents for a 12-year-old old patient. And in this picture, you can see here that we have swelling of the optic nerve, but I already mentioned that optic neuritis in case of neuromyelitis optica should be unilateral or bilateral, and also it sometimes involves in chiasma. And I think that I have picture of neuromyelitis optica which affects chiasma also, and I will show you it. Rather than this, what should be ocular signs and symptoms for neuromyelitis optica? It is that sometimes patients will have optic disc swelling, and they should also develop optic atrophy. But in case of spinal cord involvement, here you can see the picture of spinal cord involvement. I would like to mention that in case of neuromyelitis optica, we have damage of gray and white matter also. This is another difference between NMOSD and also MS. And here you can see this is the spinal cord damage in case of patient with NMOS. And as you can see here, this damage is very longitudinally extensive, and mostly it contains at least 3 vertebral lengths, right? And it is not discontinuous. It is longitudinally extensive, and this demyelination is located in the central part of the spinal cord, as you can see here. It is another difference with MS, because we know that MS is characterized by discontinuous damage of the spinal cord, and we should see this discontinuous hyperintensity into the MRI picture, for example. But in case of NMOS, it is longitudinally, as we can see here, right? Now, it should be like this spinal cord involvement should be appeared as a complete spinal cord syndrome, and patient should have motor dysfunction, also autonomic dysfunction, like it is sphincter dysfunction and so on, and also sensory loss. And as I already mentioned, ARIA post-trauma syndrome, which is very severe and very important, because some of patients will be hospitalized because of severe symptoms, which is caused by ARIA post-trauma syndrome. Okay, here we can see this ARIA post-trauma syndrome more detailedly. Here you can see this is the part of ARIA post-trauma. And I would like to compare NMOSD with MS. I already mentioned that ARIA post-trauma syndrome is characterized by nausea, vomiting, and hiccups, which will be seen in NMOSD patients, because I already mentioned that 4% of patients with NMOSD represents with ARIA post-trauma syndrome. And here, in case of MS, we don't have involvement of the ARIA post-trauma. Also, I would like to mention one of the difference between MS and NMOSD. We know that in case of like multiple sclerosis, we have in the brain imaging, we have demyelination and hyperintensity plaques beside to the lateral ventricles. But in case of NMOSD, mainly this it will cause like hyperintensity to the third and fourth ventricle. This is another difference between MS and also neuromyelitis optica. Here in the next slide, I would like to show you transverse myelitis and what should be the presentation for transverse myelitis. Here you can see it is longitudinally extensive, and it is more than 3 vertebral lengths. This is just characteristic features of transverse myelitis, which should be seen in case of MS and also Neuromyelitis Optica Spectrum Disorder. So I want to mention that it is not specific for neuromyelitis optica. So this kind of sensory or motor impairment, or maybe autonomic function impairment, should be seen in both of them, right? Like it is spasms, limb weakness, paralysis, and so on, bladder and bowel dysfunction. Now here I have a picture of optic neuritis. This is represents for optic neuritis, and also it represents for involvement of optic chiasma, as I wanted to show you previously. And I would like to compare optic neuritis in patient with multiple sclerosis and the patient with neuromyelitis optica. I already mentioned that in case of MS, it is more likely unilateral visual loss, but and also it is not permanent, right? But in case of neuromyelitis optica, this vision loss should be unilateral or bilateral, and it is more severe compared to MS. Sometimes it will cause development of blindness. So here you can see in this table, vision loss should be caused by neuromyelitis optica spectrum disorder and also multiple sclerosis, but blindness is should be caused seen in patient with NMOSD, right? And I already mentioned all this information. And now I would like to tell you what is the difference between clinical course of neuromyelitis optica spectrum disorder and multiple sclerosis. This first one represents for neuromyelitis optica spectrum disorder, and it attacks. As we can see here, it is characterized by recurrent attacks, and it is not fully recovery always, right? It is characterized by incomplete recovery, as you can see here, but in compared to multiple sclerosis, it is characterized more likely relapses, and patients sometimes will be near complete recovery, and of course after that it will have again progressive course. But in case of neuromyelitis optica spectrum disorder, it is always same. We do not have recovery at all, right? And here we can see some of the information related to patient with neuromyelitis optica. 67% of patients with optic neuritis should have partial or maybe no recovery, and 83% of patients with transverse myelitis also they had partial or no recovery in case of NMOSD. So as you can see here, it is much more severe rather than multiple sclerosis. About this slide, I would like to tell you, mostly I determine difference between multiple sclerosis and neuromyelitis optica. And one of the very important difference which I would like to mention, it is oligoclonal bands. We know that in case of multiple sclerosis, we used to detect oligoclonal bands, but in case of any neuromyelitis optica, it is not specific. So this is another difference between them also. And in this picture, I have two picture of damage of spinal cord, transverse myelitis in patient with, and one of them is in patient with neuromyelitis optica, and another one in patient with multiple sclerosis. No, I have already this explanation here, but I hope it is very clear for all of you that in case of first one, it is longitudinal and more likely central demyelination of the spinal cord, which is represented for neuromyelitis optica. And in another case, as you can see here, we have only discontinuous damage and demyelination and hyperintensity into the spinal cord, and it is not directly into the center. It is little bit in the peripheral part, right? So it represents transverse myelitis in patient with multiple sclerosis. But if when we're talking about differential diagnosis between neuromyelitis optica and another condition, it is not only multiple sclerosis, but as I already mentioned, because it is sometimes misdiagnosed, like neuromyelitis optica is misdiagnosed as in multiple sclerosis. This is the reason why I mentioned a lot of information between them. But also we should take it mention, for example, acute disseminated encephalomyelitis. Also, should be differential diagnosis should be made between SLE or Behçet disease, and also myelin oligodendrocyte glycoprotein associated optic neuritis, because all of them are characterized by same characteristic features, but of course they have different causes. And what about diagnosis of neuromyelitis optica spectrum disorder? We need three main things, and it is very logical. At first, it is at least one core clinical characteristic. In general, we have 6 core characteristic features for neuromyelitis optica or DEBIC disease. First one, I already mentioned, optic neuritis, acute myelitis or transverse myelitis, and ARIA post-trauma syndrome. This is 3 main one, but also we have 3 additional. It is acute brain stem syndrome. Also, it should be symptomatic narcolepsy if we have involvement of hypothalamus, or maybe it is acute diencephalic clinical syndrome. And also another one, it is symptomatic cerebral syndrome with NMOSD typical brain lesions. So these are the core clinical characteristic, and at least one we need to make diagnosis. But of course, it is not enough, right? At first, when I started neuromyelitis optica, I mentioned in pathophysiology that here we have production of autoantibodies, which are IgG antibodies against aquaporin channels, AQP4 channels. So if we have, we need another like positive test for AQP4 IgG antibodies. And the third one, it is to make exclusion of alternative diagnosis, as I mentioned in this previous slide. And here I have test for AQP4 IgG antibodies. We have two main tests how we can make diagnosis of the autoantibodies. It is one of them, it is cell-based assay, and another one is ELISA. And as we can see here, higher sensitivity is characterized for cell-based assay, so it is more like it is preferred to use for diagnosis of David disease. And now I'm going to step by step finish my presentation, and I would like to tell you what could be the treatment of David disease in case of acute attacks and in case of long-term treatment. Now, in case of acute attacks, it is very like similar to MS because we should use intravenous glucocorticoids. But in case of long-term management, we are going to use humanized antibodies, which will be against CD, mainly it is concentrated to CD19 marker, but not only. So, for example, we have some medications like it is rituximab. Here you can see rituximab. Also, we have eculizumab and also inebilizumab. I would like to tell you what is the difference between them. All of them, of course, they are humanized antibodies, but they have different mechanism of action. For example, in case of rituximab, it's is a humanized antibody against CD20. And in case of inebilizumab, as you can see here, it is a humanized antibody against CD19. And what I want to mention, we know that this IgG antibodies is produced by plasma cells, and these plasma cells came from the B cells, right? So we know that B cells, they have markers CD19 and CD20. So by use of this humanized antibodies, like for example rituximab and inebilizumab, we should make to inhibit production of plasma cells and of course production of IgG antibodies against aquaporin channels, which are located to astrocytes. And another one, it is eculizumab. What is the mechanism of action of these humanized antibodies? This humanized antibody will inhibit production of complement protein. It inhibits to make formation of membrane attack complex, which is one of the reasons why we have primary damage of astrocytes, and after that why we have damage of oligodendroglyocytes. So this is the explanation of mechanism of actions of some humanized antibodies. And the last part of my presentation is about prognosis. In general, it is, as we can see here, one study only demonstrated that only 22% of patients will have fully recovery, but 6% showed no recovery at all. This is what I already reviewed in previous slides, because it is characterized by relapses, and also it is higher chance to do not recovery at all. And here we can see severe visual defects or motor impairment is present in about half of patients within 5 years of disease onset. I already mentioned all this information also, because sometimes optic neuritis should be the in patient with David disease should be the reason of permanent visual loss. And the last one, it is that disease-related mortality in case of David disease is most commonly due to neurogenic respiratory failure. Okay, and these are my references. Dr. Sain?
Yeah. Oh, we're done? Okay, let's see. So, Gwen. So.